Infectious and inflammatory cardiac disorders. The first disease process that we'll talk about is rheumatic fever and rheumatic carditis. This is basically rheumatic fever is going to follow a group A streptococcal infection, while rheumatic carditis is an inflammatory cardiac manifestation of rheumatic fever. So they kind of go hand in hand. These clients may experience a mild fever, a rapid heart rate, and abnormal heart rhythm. They may have red spotty rash on their trunk that disappears quickly and may leave irregular circles on the skin. Joints may be swollen. They may see warm, red, and painful joints. They may have a heart murmur and pericardial friction rub. They may also have chorea. An ECG might show changes in the heart, but there's no specific lab test. But in ESR, the erythrocyte sedimentation rate, or a C-reactive protein, may be elevated. And remember, the ESR and C-reactive protein are both going to show inflammation somewhere in the body. The IV antibiotics that might be administered would be like penicillin or vancomycin or zithromax. Surgery might be done for constrictive pericarditis and damage to the heart valves. And we may also give aspirin to help prevent formation of clots. We may give steroids or prophylactic antibiotics prior to invasive procedures. So this is important for you to remember. When a client has had either valvular disease or rheumatic fever with carditis, then we need to give prophylactic antibiotics prior to any procedure that is invasive to help prevent infection, because if that infection gets to the heart, then it could be very serious. This includes even something as simple as having the teeth cleaned. So as nurses, it's important for us to administer prescribed drug therapy, diversion activities, bed rest, small frequent meals, sodium restrictions, increased fluids, and protein and calories may be required. With infective endocarditis, we have inflammation of the inner layer of heart tissues. It's considered an autoimmune response. Microorganisms that might be involved would include bacteria, and this would be streptococcal or staphylococcal, and fungi. Causes of infective endocarditis include prolonged IV therapy, insertion of cardiac pacemakers and cardiac catheterization, or even a Foley catheter. These clients usually have an acute onset with fever, chills, muscle aches, joint pain, ossular nodes, splinter hemorrhages, the Janeway lesions or Roth spots, petechiae, enlarged spleen, and heart murmur. Vegetations from the infection can actually break off from those valves and then cause emboli. These clients may experience anemia, leukocytosis, blood cultures, transesophageal cardiography, and ECG. As far as management, medically, we're going to give high doses of antibiotic therapy, bed rest, and valve replacement. Again, these clients would require uh, prophylactic antibiotics uh, for any potential invasive procedures. We should encourage the client to limit their activity and assess for changes in their weight, their heart rate, and rhythm, and administer antibiotics. Which of the following histories of a client would relate to a diagnosis of bacterial endocarditis? A previous heart catheterization, strep throat 4 weeks earlier, open reduction internal fixation of the left hip last year, smokes 2 packs of cigarettes a day. That will be that history of strep throat a month ago. Pericarditis is inflammation of the pericardium or the sac around the heart. It can be primary or secondary. Secondary would be related to endocarditis, myocarditis, chest trauma, myocardial infarction, or post-cardiac surgery. It can lead to fluid accumulation, which can lead to cardiac tamponade, which basically would be accumulation of fluid in that pericardial sac. And if enough fluid accumulates, it can begin to compress the heart. And then ultimately, it can begin to interfere with the pumping action. And we call that cardiac tamponade. And pulsus paradoxus. These clients experience fever, malaise, a heaviness in their chest, precordial pain. Moving and breathing will worsen the pain, but sitting upright and leaning forward is going to help lessen the pain. These clients may have a pericardial friction rub, so we auscultate the heart and we hear a rub with every beat. And they may also experience severe hypotension. We're going to look at the ST segment of the ECG. It will be elevated. We can do a chest x-ray, an echocardiogram, white blood cell count, or the erythrocyte sedimentation rate, the ESR, to determine inflammatory process. Medically, treat it with rest, analgesics, antipyretics, NSAIDs, and corticosteroids. Surgically, we treat it with pericardiocentesis, pericardiostomy, pericardiectomy, or decortication. Nurses should always assess the pain, auscultate heart sounds, assess for jugular vein distension, a persistent cough, dyspnea, fainting, anxiety, and changes in pulmonary function. A patient with pericarditis has been admitted to the cardiac intensive care unit. The nurse caring for the patient knows that the most common clinical assessment of pericarditis is what? Select all that apply. Diaphoresis, chest pain, elevated cardiac enzymes, friction rubs, or all of the above. This would be all of the above. Thrombophlebitis is inflammation of a vein accompanied by a clot or thrombus formation. This can include a deep vein thrombosis, DVT, or pulmonary embolus. The inner vein is going to be irritated or injured, and platelets will start to clump together and form a clot. Then we see the Virchow's triad, where we have venous stasis. In other words, blood's not moving very well. Excuse me, we have altered blood coagulation, or we may have trauma to that vein. We might see an increased risk with inactivity, Oral contraceptives, especially if the oral contraceptives are accompanied by smoking. Excuse me. These clients will have discomfort in the affected extremity, calf pain that increases on dorsiflexion or that positive Hohmann sign of the foot, heat, redness, and swelling, capillary refill that is less than 2 seconds, fever, malaise, fatigue, or anorexia. We can diagnose with a Doppler ultrasound, venography, or an IPG. Medically, we encourage ambulation prior to the formation of a DVT to help prevent clot formation. Excuse me. And also to prevent blood stasis. We can do those compression garments, such as compression stockings or compression bandages, anticoagulant therapy, and continuous warm, wet packs. Surgically, we can do thrombectomies, a ligation. We can also place a vena cava filter to help prevent emboli from traveling to the heart and lungs. So we as nurses should always obtain a history of blood clots, their risk factors for blood clots, obesity, contraceptive use. We're looking at that Hohmann sign, again, asking them to pull the toes toward the head, and if they have pain in the back of the calf, that's a positive Hohmann sign. Capillary refill and pulmonary embolus, which would be exhibited by chest pain and dyspnea. Arteritis is inflammation of the arteries and damages blood vessel walls, reducing blood flow to the organs. We might see symptoms and complications that depend on which arteries are affected and the degree of damage. Takioso's arteritis is also known as aortic arch syndrome or nonspecific aortoarteritis, in which the walls of the aorta are going to grow thicker, and that leads to an insufficient blood and oxygen supply to the rest of the body. Complications can include a loss of vision, cardiac disease, hypertension, fainting, joint pain, muscle pain, fatigue, malaise, fever, and night sweats, weight loss, and aortic aneurysms. Giant cell arteritis or temporal arteritis is an infection of the superficial temporal artery and other arteries that supply blood to the head, eyes, and jaw. GCA generally will start out with flu-like symptoms, including severe headache, fever, aches, loss of appetite, and malaise. And complications can result in vision loss, jaw pain, scalp pain, and other symptoms. And then we have polyarteritis nodosa, which is an inflammation of the medium and smaller arteries that carry blood from the heart to organs and tissues. Symptoms include headache, fever, muscle aches, joint aches, fatigue, weakness, loss of appetite, rashes and sores that may look like bruises, pain, burning, numbness, and weakness in the hands and feet, renal failure, high blood pressure and edema, heart attacks, heart failure, or pericarditis. There is an unknown cause, but it is believed to be an autoimmune disorder, and we treat it with corticosteroids, antibiotics, or surgery. Most people will make a recovery, but treatment can take up to 1 to 2 years. And your post-test.